So moving ahead, I'd like to invite our chairperson, Dr. Shailesh Bondarde. Sir is a senior consultant medical oncologist at Apex Wellness Hospital, Nashik, and Dr. Nalini Kilara. Ma'am is a senior consultant medical oncologist at MS Ramaya Memorial Hospital, Bangalore. So over to you, sir.
Good evening, and at the outset, I would like to thank Dr. Sudeep Gupta and Dr. Shonanak for giving me this opportunity. Straight away, we go to the panel discussion, and we have moderator as Dr. Prasad Narayanan, who is a good friend of mine and is a senior medical oncologist at Bangalore. Over to you, Prasad.
Thank you, Dr. Shailesh. Thank the organizers for the opportunity. So maybe we will start while I try to share the screen. We have the panelists are Dr. Anubha Bhartwar, Dr. T.P. Sahu, Dr. Arun Warrier, Dr. Abhishek, Dr. Chirag Desai, Dr. Rajiv Rajendranath, Dr. Manish Kumar, and Dr. Bhavna Parikh. I hope that all the panelists are there. So
Yes,
when I try to share the screen, I can start asking Dr. Shailesh Bondarde,
you can share the screen, sir.
Do you believe that we will cure metastatic breast cancer, which is HER2 positive? That was the parting statement from our previous speaker.
Well, always hope so. Well, the day I started my practice. I mean, there was not even trastuzumab which was available. And I think we have come a long way. So maybe 10 or 15 years down the line, who knows?
Sure. So 13 abstracts, 8 panelists and 45 minutes. I'll try to keep the discussion going. The previous speaker has actually summarized many of the things which I would have discussed. So we will try to use this data in the Indian scenario. So we'll discuss about some of the new anti-HER2 options, the long-term data of some of these trials, practice changing outcomes. Then specifically in the Indian scenario, the long versus short anti-HER2 treatment, the endocrine therapy data, which I'm sure we will be all interested in discussing. The one abstract on immunotherapy and about the subcutaneous trastuzumab. So we'll start with this trial of pyrotinib, the fourth trial. It is pyrotinib plus capecitabine versus lapatinib and kevin. And the study was a positive study in terms of the progression-free survival improvement. The updated overall survival shows a 2-year overall survival of 66% versus 58% in the capecitabine arm. So it was seen in most clinically relevant subgroups in this study. And another study of pyrotinib also was presented in the ASCO meeting recently. That was specifically in the brain metastasis group. So this had 2 cohorts actually. One was the patients who did not receive any local radiotherapy. That is the patient who had brain metastasis and who have not progressed after radiation. The other group is a even tougher group where the patients have progressive brain mets after radiation. Small study. And there was a PFS of 11.3 months in one cohort and 5.6 in the other cohort. So I'll start with Dr. Anubha. So where do you, we just heard about the role of how we are going to treat HER2 positive metastatic breast cancer specific to brain metastasis. So where do you think pyrotinib will find its place in future? TDM1 itself is struggling to find a space now. Trastuzumab deruxtecan almost taking the second line setting, and we heard that in active brain mets, maybe tucatinib is the should be the second line option. So where do you place pyrotinib?
So I think the previous speaker was quite clear in that fact that he said that we have to look at brain mets in the setting of whether it is active and progressive or whether it is stable. So I think pyrotinib actually tucatinib plus trastuzumab plus capecitabine is what he has clearly implied that we should use if there is progressive brain mets or active brain mets. And I think maybe pyrotinib would be another one which would come into play in this area. Because the others did not have this subgroup of active brain mets where you talk about the trastuzumab deruxtecan and other TDM1. They have not looked at patients who are progressive. So I would say that especially for the patients with progressive brain mets with stable disease elsewhere, that would be where I would use agents, the small molecule inhibitors like tucatinib and pyrotinib.
Sure, I think we will have a situation where we have 2 or 3 options in such patients, and we'll have to choose from one. And Dr. Chirag sir, if you can think about, if you want to design a study with pyrotinib now, which setting you would take?
I will conduct the study as third line after Trastru with or without Pertu and Taxane and one of the antibody drug conjugate in the third line. I will want to use pyrotinib.
Okay. I think there's a background noise which is coming. If that can be stopped, it would be appreciated. So
Yes,
we'll go to the next study. This was also discussed actually, the trastuzumab docarmazine study. And Professor Gilena actually said that he doesn't think that this will make a huge difference in the impact. Let us see what the data we have already seen. Positive study. The PFS improvement, it is impressive, but not that as impressive as the deruxtecan data. So ocular toxicity seen in almost 1/5 of the patients. So that was the one which may be taking away this drug from being a first choice. So we'll ask Dr. Manish. So do you have, what is your opinion? Do you think that this drug will have add any value in our setting?
Yeah, thank you. Actually, as you yourself said that this is a positive study, so that gives us some way of hope going ahead. But before we use this agent, we have many other agents in our hand which are time tested and which are easily available. So that is one. And secondly, I feel ocular toxicity is going to be a major concern, because though grade 3 toxicity in more was in 1/5 of the patient, but overall almost I think 50-60% patient or maybe more at ocular toxicity. So that can also be a concern that we need to look into, So I don't think this will find a place so soon in our patient treatment protocol.
Do you think it will find a place in future clinical studies? Will studies?
Yes, definitely. Yeah, definitely. Since it's a positive study, there's no reason that we should not consider it for further studies. But yes, as I said, there are many other agents which will come much before this. But yeah, for future studies, yes, it should find a place, definitely.
Okay, so I think we will move on. We will take up certain other studies which are of more interest in the Indian scenario. So this is a study which I think can be discussed in an Indian scenario in a specific way. It's a fixed dose combination of pertuzumab and trastuzumab as a subcutaneous injection in HER2 positive early breast cancer, and it's a non-inferiority phase 3 study with a primary endpoint of pharmacokinetic equivalence actually, and it met the primary endpoint of the pharmacokinetic equivalence in subcutaneous form. So safety was similar between the treatment groups and in line with other trastuzumab, pertuzumab chemotherapy trials. So Rajiv, are you interested in getting a subcutaneous trastuzumab in your practice? How will it help you?
So yes, the obvious answer would be it will reduce the the infusion time and the patient convenience. But when I went into the detail of the study and the drug insert, it is slightly complicated, because it actually it comes in a preparation of 1,200 mg of pertuzumab and 600 mg of trastuzumab fixed dose for the loading dose, and 600 mg of pertuzumab and 600 mg of trastuzumab in the maintenance dose. Now, almost 95% of our patient doesn't require this dose if you look at the conventional dosing. So straight away, one Indian perspective I can think about is whether we can split the dose and use it for 2 patients if you have the loading dose vial. But otherwise, when you go into the drug insert, they say that you have to have all the precautions that has to be taken to prevent anaphylaxis. So our idea of giving in a small clinic or in a peripheral center would also be very difficult, because they say all anaphylactic precautions and all the resuscitative measures should be there when you are using the subcutaneous preparation also. The third one I was concerned is it has to be given only in the thighs, and the loading dose has to be given over 8 minutes and followed it up with the 20 to 30 minutes of observation. So that's around 45 minutes of clinic time, and we are using 120 minutes or 90 minutes in the subsequent doses in the IV itself.
And in many patients, we will be using intravenous chemotherapy. So we'll have a chemo port in place. And most of the time we would need a port for maintenance also. In that situation, it's only a very few small subset of patients I would feel in Indian context he will benefit. And the dose for us will be more apt if the generics come with the lower dose fixed dose combination.
Super. I think you have nailed a lot of points there.
Can I add something? Can I add something,
yes,
Dr.
please,
Prasad? Yeah.
Please.
Yeah. Yes, I completely agree what has been said by my previous speaker. And also, if you see the dose, it is almost 10 to 15 ml. So 10 to 15 ml subcutaneous injection is not going to be that simple. That is what I feel. It is not like GCSF or something which is just 0.5 ml. And as he very correctly said that all the necessary precautions need to be taken. So ultimately, simplification is to what extent I really wonder. And these kind of preparations, usually they are always expensive compared to IVs. I mean, so many generics we have now IVs that it is economical nowadays to give trastuzumab, not yet pertuzumab, of course. But we still have to wait whether we can make it really convenient for our patients in our setup. That's what I feel.
Narayan?
Yes, Sahuji. Yeah.
I little differ from my previous two. I feel that with chemotherapy, it makes sense to give the IV. Because you already have a line and you have used a chemo port and infusion. But once you are doing the maintenance therapy in the adjuvant or probably the metastatic, I think this makes sense.
How
Keep
will
the
you
cost
pull out the
apart.
port after chemo?
No, I will not, but I will. What I'm coming to is evidence based. If you look at the previous trials of a phase 2 and the choice was given to the patient, 85%, overwhelming 85% agreed to take the subcutaneous. I did have the concerns about the 10 and 15 ml, but the trial very clearly pointed out that was not, and even the side effects of skin was very minor. So point taken that on a randomized way, and if the patient preference is an overwhelming 85%, and I do agree that all of us, even the hospital charges and hospitalization will be much lesser. So I put the cost of the drug apart, the generic and the other part can be spoken. But post chemotherapy, the infusions, I think this has a place, and that will probably pick up, and people will afford, and those who can afford pertuzumab at that cost will choose this subcutaneous. That's my take on it, because 85% is too overwhelming support. So that's what I feel, and we have to respect the patient's decision.
I think we will move on. I think it's great to have two different views
and
on
the
this.
Efficacy is same. And the efficacy is same till now.
Right, agree. So we have to take it in the two different contexts actually. When trastuzumab as a single agent is being given versus when you are giving in combination, which is what most of our metastatic breast cancer patients also go through. If you take 80 to 90% will be on single agent trastuzumab. It's still in India. So we will move on. This trial was described. It's a winner in terms of the, we heard the first author itself presenting the data and placing it exactly where he wants to place it in metastatic breast cancer treatment. We saw the data. There is nothing much to discuss about the efficacy here, and the safety is also very well established. So we will go to Chirag sir. So, sir, you have, I mean, tomorrow, if you can get tucatinib for all patients, where would you give it? Would you place it? Will you keep it for some patients who will be progressing on your first line? Like we all have now patients who have received trastuzumab, capecitabine, I mean, lapatinib, then sometimes TDM1, and where will you want to use it? You want to use it upfront in the second line setting in brain metastasis patients, or you want to keep some options to prolong life, as we always think in India?
So, I mean, I will divide my question in a couple of points. The first is whether the patient is having brain metastasis or not. If the patient does not have a brain metastasis, I will use it as third line right now after TDM1. When deruxtecan comes, then it will be a different story altogether. But at present, without brain metastasis after TDM1, that is the first thing. Second thing, if the patient has brain metastasis, whether it is active or inactive brain metastasis, if the patient has brain metastasis that has been treated, controlled, not symptomatic, I may use it ahead of or after TDM1. But if the patient has active brain metastasis, definitely it is ahead of TDM1.
So presently, with the available drugs which you have, how do you separately treat patients who have brain metastasis, metastatic breast cancer, HER2 positive?
So at present, if the patient has already been treated with TRUST-2 per-2, and the patient develops brain metastasis, if the patient is symptomatic, I go for radiation, and then I give TDM1. If the patient is not symptomatic, I give TDM1. If the TDM1 also has been given, I will go for lapatinib capecitabine.
Sure, sir. So I think it's yes. Okay. This is the next study. I think another blockbuster study actually, which is coming from third line to second line, and I'm sure it will take up in first line as well. Because now we are all searching for patients for the studies of trastuzumab deruxtecan in patients with who have failed our usual treatments, and we find that we have only studies in first line, which is happening in India. So I think we have seen this. We can drive a few cars between the curves actually, and the 80% response rate in second line and all is like exceptionally good in metastatic breast cancer. And maybe this is the study which has made us think that we will be curing metastatic. We saw the subgroups. There is nothing to pick here. So overall winner drug actually. So Dr. Bhavna, you think that we should just forget about TDM1 now?
If trastuzumab deruxtecan becomes available in India, then definitely we will be preferring that drug, looking at this particular paper which you just showed all the slides. But up till now, because that we are not having the drug, I'm also giving TDM1 as our next line of option after the primary treatment. But looking at this data, I think the curves have separated very widely. And I am sure that medical oncologists would prefer giving this drug first rather than giving TDM1. In fact, so many new drugs have been coming that it is becoming a little difficult to grasp and grasp each one of them separately, and even trying to find the exact place for each one of them. I think we may be spoiled for choices in future. That is what it looks like to me.
Sure. And any experience with the drug? I think many of our sites have the trial now going on in first line setting.
Yes.
So you use the drug. Any comments on the safety profile? Yeah.
Any comment on the
safety profile or experience?
No experience actually, but some of the data was discussing about the ILDs and things like that. But I think every new drug which is coming, that problem will remain. But of course, if we are going to use, say, also the place where you are using TDM1, and if that patient has severe neuropathy, then these are the patients where we can think in considering them for trastuzumab deruxtecan to save them from neuropathy. So that also could be one indicator. So many diabetic patients we already have, or they might have neuropathy from their previous therapy and already persistent neuropathy. So in that kind of a situation, I will probably consider this drug even in the earlier line of treatment.
Sure. So we'll move on. So now we go to one study and the meta-analysis actually, which I'm sure we'll have a longer discussion on. So this is the 9 weeks versus 1 year adjuvant trastuzumab, the shorter randomized trial. Good design actually. Initially giving the trastuzumab with docetaxel and then giving the chemotherapy. So we just have a cursory look at these graphs. I think low risk and intermediate risk that formed around more than almost 85% of the patients in this group. There is nothing much to choose between the treatment arms here. And if you take the high risk, which was a small number of patients, there is a difference. Similarly, in the overall survival as well. So the hazard ratios are like the question of whether Virat Kohli may continue as captain kind of a situation. So patients
he has designed update. He has designed.
Oh wow.
Yeah.
Okay, that is shocking. So Arun, you are there? Arun? So, now I will ask you, if this was a non-inferiority trial of a new drug, what do you think that it would have become standard of care? The curve which I showed you just now.
Yeah. Prasad, thanks for giving this question beforehand, because for answering, I had to go back and see the statistics for that. So basically, the way in which you design a non-inferiority trial, so that it's all set beforehand, because non-inferiority trials are what we see in all these short-term studies. I'm sure in the next presentation that will be coming up. So they are all looking at non-inferiority trials, where it is not just the they look at the clinical outcomes also. So it's a basically statistical way of designing things, and it is all designed upfront. So we can't go back and do a post-hoc analysis on the results. So here, if you see the DFS, the confidence interval was 0.98 to 1.42. So it is 0.89 to 1.42. The overall it came to 1.13, but the predefined thing was 1.29. So they're very strict about this. So if it crosses, say, the non-inferiority crosses the day, it is not more than 1.29. So here it was, the confidence interval crossed 1.29. It was 0.89 to 1.42. So it was a very statistical way of looking at things. And I'm sure that even if it was a new drug, the statistics will overpower that, and it won't become the standard of care. It was a clinical thing, and it's a predefined endpoint.
Do you use 9 weeks adjuvant trastuzumab in any of your patients?
Here basically again one more thing was that the cardiac things is one thing which they are again giving focus, which looks very unusual. It was 12% in the long arm. I am sure that we are not saying that, versus 4% in the short arm. So another thing was that all the patients in the short arm receive anthracyclines after trastuzumab. Whether that had an impact, I am not sure. And again, 12%, I am sure that we are not saying with 1 year trastuzumab. So the cardiac thing is also a little hazy about this trial. And definitely it will be the low and intermediate risk group, which formed a 90% of the population, tumors less than 2 centimeters and who are node negative, or if they are or any node positive. More than N2 will be high risk. And in the clinical practice, to get a less than 2 centimeter lesion is very, very rare. So it may be a very rare patient in which I will try for based on this trial. All the other things like affordability, cardiac things will come later.
So we'll go to the meta-analysis, individual data meta-analysis from the 5 studies, almost 11,389 patients. From one trial, they had only the trial published data. Other all was individual patient. So 5-year IDFS rates were 88.46 and 86.87. Non-inferiority limit was 1.19. So this was when you take all the 5 trials combined. When you take the 6 months one combined, I think the hazard ratio is 1.09. The non-inferiority p-value is 0.02. If you take the 9 weeks one, definitely there is a non-significant. It is not non-inferior. So this final analysis, they said that 6 months versus 12 months is non-inferior. 9 weeks versus 12 months has not been confirmed. So we'll go to Sahu, who has updated us about Virat Kohli. So what do you do? How short is the short duration? So is 6 months the non-inferior?
See, I definitely look at the clinical characteristics. Probably if it is more than 4 nodes in a HER2 positive, I would opt for a 1 year if the patient can do that. Because if you look at the major weight of these trials come from the Persephone. And if you look at the study, around only 15% of these patients were high risk as defined in the shorter, like more than 4 nodes or more than 5 centimeters. If you look at it, that really constituted a minority of the whole Persephone data of around 4,000 odd. So still now, if given a choice, finance is not an issue. I would probably, for these patients who are node positive, probably more than 4 nodes and 5 centimeters or beyond is where I would, or ER negative again, I would probably go for, along with this characteristic, for a longer duration. But with these data now evolving, the data is now there. I think we have an option of going for a shorter duration for those early tumors, node negative. So that is how I would differentiate now. And this is what gives me confidence that, okay, I'm not doing any harm. The 9 weeks is for a very specific, very early, good prognostic patients for HER2/neu is something where the 9 weeks also would come in my practice.
Sure. And do you think that this question will be addressed anytime now?
I think there have been 3 or 4 meta-analysis in last 2 or 3 years. One from our group in Tata also. Dr. Sudeep is there, the author, Seema and Sudeep sir. I think that they also put forward the conclusion which Dr. Sudeep and Seema put forward is very, very forthright. That we think probably that is the way to go for shorter duration. And they would need further. The wording itself says that shorter duration is not for all. I think that's where, and we have Dr. Sudeep already on this, he may comment, but that's what I felt when I read the conclusion of their meta-analysis, also the individual patient meta-analysis. So I feel we need to now differentiate, not put them all into one basket. The good risk, intermediate probably could go for shorter, and the high risk have to go for the 1 year. That's my take on it.
Sure. I think that is the message. Sudeep sir, you want to add anything to that?
No, I agree with what Dr. Sahu said, that perhaps in good risk patients or those who cannot afford or those who have cardiac issues, perhaps shorter durations are appropriate. But for the high risk patients, perhaps 1 year. The other thing that came out in our meta-analysis as well as that of Dr. Earl was that if one does want to abbreviate, perhaps 6 months might be better than 9 to 12 weeks.
Sure,
Yes.
sir.
The only thing.
So we'll go to a trial which I
and
was...
last, Narayan, I think some trastuzumab is better than no trastuzumab.
Sure,
That's the last game.
Sure. So I was waiting for this data to become negative actually, because if this also comes positive, we don't know what the patients will do when they get a high risk positive early breast cancer. So neoadjuvant atezolizumab added to trastuzumab, pertuzumab, and then giving for 1 year along with trastuzumab and pertuzumab. And in this, actually, the PDL1 positive group had a lesser the co-primary endpoint of PAT-CR, and the study was negative, and there were 5 deaths in the atezolizumab arm. So, negative study. Dr. Abhishek, do you think that this is the? What is your opinion on this study? I mean, do you think there is any further question to be asked about atezolizumab in this group of patients?
2 things. First, you already showed the PAT-CR was worst in the PDL1 arm, so that itself confuses you a lot. So that tells you there are things which we don't know. A lot of data needs to come about TILs, which they think is more important in this subset of patients more rather than PDL1. So it's work in progress. It is going to come. Maybe it takes some time in the future. Second thing is, as an oncologist, what always the basic concept still remains: if you have a driver mutation, probably that works the best. The drugs which work on that works the best. Whether immunotherapy adds anything to that in the HER2 positive subsets, time will tell.
So it is almost like saying perfection ko improve karna mushkil hai.
It's difficult.
So, right. So we will go to the affinity study, the adjuvant, the long-term data, which was presented by Martin Picard. And if you see the IDFS, which was the primary endpoint, there was the interim overall survival analysis did not reach the p-value required for statistical significance. 6-year overall survival were 95 versus 94, with the number of deaths which are required having happened in this study. The node positive cohort continues to get the IDFS benefit. No benefit in the node negative cohort, and some confusing outcome in the hormone receptor positive group actually. So, sir, Chirag sir, what do you think now after seeing this? Will you consider the giving pertuzumab in the adjuvant setting, or you think that it is better to give neoadjuvant with a PAT-CR based escalation, which will be more pocket friendly also?
So, if the patient is given a choice, I will definitely go for neoadjuvant rather than adjuvant. But this trial is about adjuvant. So we have to determine whether we are the believer of IDFS as the optimal endpoint or not, which I believe I am tending to agree with IDFS. That is mainly for getting the drug approved for marketing for a particular purpose. And then the onus is on us, our group, our academic group. We have to pursue the patient for a long time. And at the end of 5-10 years, we have to determine whether the drug is really worth or not. So at least for node negative, it's a useless drug. For node positive, it appears that there is a 5% difference that has been maintained over last couple of analysis. And if that maintains for a longer time, if the graph separates further, then it is going to be the drug of choice for this patient, not otherwise.
Sure. Anyone has any comment on this study? Because it has a practice-changing implication.
Can I add something?
Yeah, I have to just add
Manish, Dr. Manish.
Yeah, what Dr. Chirag said, in a disease like breast cancer, which we have a long natural history, in the beginning, say initial years, say up to 2 years, 3 years, we can take IDFS as a point. But where we have 8 years data still is not showing any OS benefit, and going by that and using this thing in adjuvant setting, I'm not very much convinced. So
Sure.
I will rather stay away from using that regimen.
Sure, Mani. Dr. Bhavna, you were saying something? Because we have 2 more abstract to take,
Yeah, just a short comment. I think we are not yet fully convinced about adjuvant pertuzumab. That's what I think. That's what
sure. I think that's a good take-home point from that. And then we'll go to the attempt study, the TDM1 versus.
So is it a take-home for all of us that adjuvant pertuzumab is still, because in a node positive, as Chirag told, 5%, and we have changed our treatments with 3%.
So if you have a patient who has been operated and has a node positive disease, we should discuss pertuzumab with the patient.
I think that's a fair statement.
Right.
That's correct. Yeah.
So phase 2, the adjuvant, the attempt study, TDM1 versus paclitaxel trastuzumab, long-term follow-up. The clinically relevant toxicities were equally experienced in both the groups, and the IDFS was exceptionally good in both the arms. So this question to Dr. Sahu, will you consider, with the TDM1 now available with the biosimilars in our country, do you think that there are some patients who should be, whether we should discuss this data, or are you discussing this data?
No, I'm not discussing. That's point number 1. It was a data mainly to look at a better toxicity profile, which failed. But the only thing that comes out when I've read this study in detail a little bit is that if the patient wants lesser of alopecia,
right,
and this could be one of the things that could be done. That's only the one extra point which I felt. And patient with neuropathy, who have pre-existing neuropathy, this could be one of them at a higher cost, because the generic trastuzumabs are there. I'm not really convinced that I will change, or I will discuss it till some person who's really specific about alopecia and has neuropathy significant. That may be a discussion. At least I know I'm not giving something inferior, but I think it's very early days. I don't think it's practice change.
Yeah, I think that line that you are not at least giving something inferior is important. I think that is the only thing we can take from this study. It is not less toxic or less expensive, actually.
And in Catherine data, one of the main reason to stop TDM1 was neuropathy.
Right.
So that also we need to,
But in this study, because the competitor arm had 12 weeks of paclitaxel, it won actually.
That's true.
Right. So this is the last abstract. This is about the endocrine therapy versus chemotherapy in primary as primary treatment in first-line metastatic breast cancer. So we saw the graphs, we heard the discussion. So Dr. Bhavna, is there any triple positive first-line metastatic disease patient who doesn't get chemotherapy in your practice? What percentage will that be?
Yeah, when I see my patients with triple positive and we discuss all the data, and we as medical oncologists are also inclined towards obviously giving chemotherapy and then keeping endocrine therapy as maintenance. But looking at this data, we can definitely consider. And then there are some patients who are very much reluctant to take chemotherapy. And in this kind of a patient, same way, if I give them hormone therapy with anti-HER2 therapy, then looking at this data, at least we will feel that we are not doing inferior treatment for our patients. But there is a group of patients who would definitely, be happy to omit chemotherapy in their treatment, no doubt about that. And second question is, what percentage will go for a non-chemotherapy approach? Maybe approximately at least 15 to 20% of the patients.
Sure. I think that's all I have.
I just have one point to make.
Right.
I think this data, I have issues with 2-3 points. The response rates were, I have not seen response rate in any of the abstracts or anywhere. Someone is aware, please, I would like to know. Second thing is, this had 80%, as told by the previous speaker from Milan, that 80% had less than two metastatic, means one metastatic deposit. How many of us see a metastatic HER2 positive with triple positive with one disease? So I don't think I'll be changing practice. I would be still considering chemotherapy with a trastuzumab at this point of time, because I would like to see with a larger, maybe metastatic bulk of the disease. And this in the right patient, if it's a very elderly, has bone mets only 1 or 2, could be option. I totally take the point. It's nothing that it should be not considered, but should it be practice changing? I don't think it will be, for me at least. No.
If I can make a point.
Only thing that this at least gives an option. It is not compulsory to take only chemotherapy anti-HER2. That is what it is.
Does the 80% of single metastatic thing, does it affect you as a practice changing thing, Dr. Bhavna? That's the only thing.
So we have other trials as well, pertain as well as
there are other trials.
So that's a good approach, and this study is one more support in the other studies. If a patient is elderly, good performance status, otherwise candidate for hormonal therapy, having prolonged BFS after initial surgery and HER2-based therapy, why not to give just endocrine therapy with trastuzumab and pertuzumab maybe?
I think the take home from that will be that we don't have absolute clarity on this, because there is this is not like there is no one arm or one specified protocol which was used in terms of the hormone therapy. There were multiple choices there. So maybe I think it is that this gives more confidence that there is some data to actually treat some patients without chemotherapy as well in HER2 positive disease. I think I'll stop there. And if there are any other points to be discussed, I can't see much from the chat actually, other than nothing specific actually. Dr. Chirag sir wants to use duocarmazine in Gangajal movie. So that I think we'll discuss later. Okay, so that's it. Yeah, thank you.
Thank you so much, sir.
Thank you very much. Thank you.
Thank you so much, everyone.